I know it's hard to start a session right after lunch. Yes, everybody has their cold sandwiches and having a cup of hot coffee. So we would like to keep it as informal as possible. That's what we have been doing for last 2 days. So let's start. We already have a very interesting panel in front of us, and we have a very interesting topic that we are going to talk for the next 90 minutes, I suppose. So 1.5 hours. Today what we will be talking about is information, communication, and technology for public health, and we would like to see how we can go towards a healthier South Asia. And we have a very interesting, like I said, very interesting panel among us. And before going to the panel, let me introduce myself. My name is Shusmita Khan, and I come from Bangladesh. I'm a nutritionist by training, and I do public health research mostly. And what we have with us is Dr. Sandhya Ramalingam. She is the head of measurement and evaluation for Arogya World. They do a lot of work in, well, one of the things that they do is use of mobile technology for diabetes disease in rural India. So she'll be talking about that. And then we have Mr. Bobby Jefferson. When I say it, mobile technology, he's the guy. He's from Futures Group, and he does a lot of work with using technologies, how we can use it for better public health. And then lastly, we have with us is Radharani Mitra. She is from BBC Media Action, so that says it all, that how media can be integrated in communications and public health. So I'm going to give the mic to them and ask them to introduce themselves and say a little bit about what they do. We'll start from you.
Good afternoon. I'm Radharani Mitra. I'm the National Creative Director and Executive Producer of BBC Media Action in India. As Sushmita said, the name itself implies that we work with media. We are BBC's development communication arm, international charity arm, and we work across 24 countries using all forms of media. And I want to really underline all forms of media, because media is no longer just television, radio, newspapers. Media is virtually every kind of touch point that audiences interact with. So what I would be talking about today is the work we have done on mHealth for the state of Bihar. This actually was quite a new thing for me. The first time personally I and even this office, the India office, was working with mobile apps. So it's been a very, very interesting, challenging, but ultimately rewarding journey. And I hope to share some of the learnings, challenges, barriers, above all, the excitement of working with a form of media, with a platform that's reaching out to millions of people all over this country.
Well, good afternoon, everyone. I'm really glad you're here on After Lunch. I'm Bobby from Futures in Washington, D.C., but we have offices here in Gurgaon, Bihar, and in other states in India. The topic will be about technology, but it's not really about technology. It's really about how to effectively use the technology in places where there's no running water, people do not speak English, they have no power, and they don't want your technology. So I'd like to share some of the lessons and the challenges that we have faced for the past 10 years and try to share that with the audience, with you today. Thank you.
Hi, I'm Sandhya Ramalingam, and I'm head of the evaluation process at Arogya World. Arogya World is a non-for-profit organization which is actually focusing on non-communicable diseases. And today I would want to share with you some of the challenges and some of the trends that we've seen, particularly in the area of diabetes, and how we've used mobile technology to reach out to the pan-India population to actually see how we could impact their behavior towards a better, healthier country. Okay.
So let's start with the data first and see what Dr. Sandhya has to say as being the measurement and evaluation head. And how do you find do you find it hard to get from data from rural India and then transfer it into mobile technology and let them use it? I'll put more emphasis on technology when we come to Bobby, because that's his forte. But still, how do you see it?
Sure. I just want to take about 30 seconds to just explain the program itself. It is pan-India, and it's going across about 11 languages. So it was not just confined to English or Hindi. It went across urban and rural. Male, female was not a distinction. And then what we did was we had crafted these text messages towards diabetes prevention and not management. It's very important that people don't understand the difference that, before you get the disease, it's important to prevent it from coming to you. And that part of understanding, there's a big gap. You talk to any teenager, and this is going to be the biggest crisis for the country going forward. And if people don't realize and change their behavior, it is going to be like, we're going to be number one in at least having diabetes in the world. So what we did was we used a trans-theoretical model approach to understand how we should craft these messages and what is the impact, what kind of messages should we give? Just medical messages, or should it be text, just general about diabetes, or should it be lifestyle and exercise, and you should change, and what should we be telling them about? After doing that bit of research, we did create these messages. We tested it with a small population, and then we sent it out using Nokia's platform. So we serendipitously chose Nokia as a platform because they had this Nokia Life Tools as a app on their phones, and it sort of went to the mid-level phones of Nokia, so it could reach a larger population. So we sent it out twice every week for about 26 weeks across to 11 languages across pan-India, all Nokia subscribers using this middle end, not very high end, not very low end, but middle end phones. So what we were doing, that in and of itself was a big challenge. So the way we evaluated the program was we had this group of experimentals that we call, and the other group was the controls, which did not receive any messages, but they were not Nokia subscribers either. So they were open, any adult who was not a Nokia subscriber. So then we could really evaluate after 6 months what the program had done to them after receiving all the messages. So we did a test of, we did the survey before we started the program and understood what they were doing in terms of exercise, in terms of lifestyle, in terms of eating habits, and we had very pointed questions, not that do you exercise, or are you eating healthy, but we really had questions like, are you eating, how many times do you eat bhaji bonda, or very specifically tailored to the state. And then after 6 months, we did the same survey with the same people, not really same people, but within the same cohort population, to see if they have changed their behavior. Do they walk instead of taking the elevator? Do they go to the market by walk, or do they prefer a car? Questions like that, which make you, and then you can have their derived behavior. Then you can then come to a conclusion with the analysis as to has their behavior changed or not. So that's specific people, and it was like a clinical trial, and they have actually shown the lower incidence of type 2 diabetes in this group. So we can get into that in a little bit.
So with this note, we can move to Bobby and ask, like you were asking, you wanted to talk about some challenges about having mobile messages or technology in a population where we have problems with electricity, where we have problems with charging our devices, or so many other problems that mobile or having messages on diabetes might not be the priority of the people. So how do we address that?
So let me just explain a little bit as well that for mobile projects and programs, I think that one of the #1 challenges is pilots, meaning there are so many mobile mHealth pilot projects and programs. What does it take to do a mHealth project? It's very simple. You go to the website, you download the free software, and they begin to send messages to patients, to clinics, to hospitals. And now you're a mobile health expert. What that has led to is now there are at least 1,000, 2,000 different mHealth pilots and programs that are occurring without sustainability, without looking at what does it take to keep the program running, without looking at the evidence base of collecting data that says why are you using mobile in the first place, what transaction are you doing for improvements. Yes, it's great technology, yes, it's cool, but is it adding effectiveness to the program? Or do you just want to collect data? So we're also part of the mHealth Alliance. And what we're doing is we're trying to look at some of the evidence base and trying to do some evaluations around the number of mHealth projects to see which ones are more effective compared to others. The second part of that challenge then becomes not just pilots and scale up, but the population that we're serving are often people in the rural areas that do not speak English, that do not have any technology awareness, and at the same time do not have funds. So one of the big challenges we see that you have to make a decision if you're a person involved. Do you buy a phone for 10,000 community health workers, or do you use the phone that they currently have? And that's a decision you have to immediately make in the beginning, because you have to decide, do you want to scale up, or do you want to have a program where everyone is dependent on your solution? So the approach that we've taken has always been open source and freely available and very open data architecture. So I'm not for our mobile projects, we have very little funding. So our approach has always been doing what's sustainable. So we use the phones, the technology, that's whatever in your hand today. We don't buy people phones, we don't purchase iPads, we don't purchase whatever the newest technology is. Because today it's the iPad, tomorrow it's the Galaxy, the next day it's something else. And that technology curve continues to change. So even if you develop an application today on Windows 7 or iOS, I can guarantee 5 years from now, there's something that's coming next. And the public health programs have to be sustained longer than that. So again, I'll share a few more of the challenges and some of the solutions that we've encountered, but I at least wanted to set the context for my discussion.
Yeah. So now we move to, of course, Radharani Mishra, and to know about what is your experience of coming from advertising, media, communication, and then public health, and mixing it with mobile. You were saying about your Bihar experience.
Yes.
So
I think the mHealth stuff that we have done for the Bihar project. So before I talk more about it, let me just quickly sum up what we had to do. We are currently working on a family health, maternal and child health project in Bihar, which is called Shaping Demand and Practices. And one of the mandates of this project was to improve the interpersonal communication skills of the frontline health workers in Bihar, the Ashas and the Anganwadi workers, and also to design a toolkit for them that would enable them to have effective dialogues with the families of the beneficiaries they visit across a 1,000-day or a 33-month timeline, which is essentially from the time a woman becomes pregnant till when the baby is 2 years old. So I think one of the first things that we told ourselves is that at the outset it looked like an insurmountable problem, because we also knew that whatever solution we think of has to be sustainable. And we didn't set out to work with mHealth. That wasn't where we began. We said that we have a difficult problem. At the moment, we have to start with 40,000 community health workers, but in the course of the next 3 years, we'd have to scale up to the 200,000 community health workers of Bihar. So how does one do this? Can you design a toolkit that can carry everything that has to be communicated across this 33-month timeline that would possibly involve, hundreds of facts, plenty of, attitudes to change, social norms? Do we then give her a suitcase to carry on top of her head? what will this toolkit look like? On the other hand, we said, so how can you really give them training which will come at a fraction of the cost of face-to-face training? Therefore, the first principle that we applied is to rethink the problem. You redefine the problem as possibly a question. So we felt that the clue to any innovation is possibly a difficult question. If you can find an answer or a solution to a very difficult proposition, therein you have an innovation, and you're not therefore doing an innovation for the sake of doing innovation. That was premise number one. Premise number two was, before we started getting or finding solutions to these two difficult answers, we went out and did a very thorough landscaping research, which was a mobile and media landscaping research. And not to our surprise, we found that in the state of Bihar, more than 70% of the rural women are illiterate, and we also found that nearly 100% of the community health workers either have their own phones or have access to a mobile phone. The third fact was that only about 9% of these frontline health workers had ever sent an SMS. We also figured out that they have phones that fortunately or unfortunately look like my phone, because I have a very old-fashioned Nokia phone with a cracked screen. But it's good. That means I know my audience, and I know what challenges they face. So most of these phones were knockoffs, Nokia, Samsung, and other things. And they were not smartphones. They were often phones tied with a little string with a cracked. So we couldn't really do a mobile app which was text-based. We couldn't think of apps that would be later not scalable, because we were not going to hand out handsets or smartphones or iPads or anything like that. And also, the most insurmountable barrier was that these people were simply not used to receiving, reading, and sending text messages. So what does one do? So I think for us, the ARC killer app has been voice. So we went back, actually we rang out the new and rang in the old. It's a twist on the common English idiom. So we went back to an age-old platform of IVR, which is voice, because voice was the only way we could answer those two difficult questions that we started out at the outset. And I think we can talk more about what we did with voice for these 40,000, and now we are in the process of scaling up, and so we can come back to the solutions in a bit.
Yeah. So before moving into the solutions, I think Dr. Ramalingam has something to say about the findings she wanted to share about. So it's maybe let's share a little bit of findings, and then Bobby can share a little bit of more of what kind of technology problems that they face.
I think I want to actually go back to what you said, and both of you touched upon the key point here is scalability and sustainability. And when we started out this project, first we were looking at small cohorts of people, but we went pan-India, and we actually reached out to 1 million consumers. And this obviously is not any longer a pilot. When we present this, it doesn't look like a pilot anymore. So then it does come with its own challenges of, how does a large-scale program look like when you just go out to the consumer world, and then how are you trying to evaluate it, and what are the challenges you're facing in terms of post-intervention evaluations and things like that. But to come back to the point of the results and what you're looking for in terms of evaluating, and was this program successful, and then can we take it to the next step? Yes, it was. We saw this from a paper that was just published in the Lancet by Dr. Ramachandran's group, which showed clearly that type 2 diabetes incidence was decreasing in the cohort of 500 people that they evaluated. And what we saw also is that although we didn't have an endpoint of incidence of diabetes, but we looked at an increase in the awareness of complications of diabetes, which went up almost, I can give you the exact numbers, but there was a significant increase of 11%. And then we asked about, how has your behavior and exercising changed? The control group did not show much of a change, while the experimental group showed a huge jump in what they were doing. The amount of food, the amount of green vegetables intake increased to about 2 to 3 servings of green vegetables. How many people increased their intake? More than 8% increase in the experimental group, and there was no change in the control group. So also with fruits and fruits intake, and then green leafy vegetables. So what this has led us to believe is that mobile technology is a very effective way to reach out and effectively use it to communicate disease-specific information. And just because, we are in this whole era of Medicare, we have to move towards healthcare. We're always thinking of, it's a almost reactive mode all the time. So in this sense, when we look at prevention and we're using mobile technology, that's where I really felt that this is this is the best medium that we can reach out to the masses and really take the message out there to be aware of what's coming and what you're doing. Just be aware of what happens when you don't eat healthy. And this I felt was, a scalable solution. But then I'll go into the challenges, like you rightly pointed out, a lot of technology challenges. How are you going to reach the rest of the people and all of that, which we can talk about in terms of challenge.
No,
but I felt heartened by the fact that the results were so good in terms of people do read messages. It's not always that, we think that people don't read the messages, but they do read it, and it has made an impact in their lives.
So just to be because I come from nutrition arena, so I have these questions. Because when we talk about type 2 diabetes and prevention of that's a very focused area of public health. And I know in this region of the world, we are having a really rise in type 2 diabetes. So we might not all understand that this is a problem, but this is actually a problem. So when you say that it's about people uptaking exercise more from the experimental group, or people are saying more green leafy vegetables, but we also know that the access to food is something else. Like maybe I want to take green and leafy vegetables, but there is no market for that thing, or I don't have the purchase power, or I want to do exercise, but my neighborhood is not safe enough to do those things. So just a word of caution is that mHealth is a way for finding a solution, but this is not the way. It's just
one of the
options that we have been saying for the last 2 days, that social media, mHealth, eHealth, ICT, these are just another vehicle of reaching the community, reaching the people. It's not the solution. So just a word of caution.
Absolutely. And there's a lot of challenges going with it, and I'm sure Bobby can address some of the challenges technology-wise.
I'd like to listen some more from Bobby, being the tech guy here.
I think, honestly, that some of the uses for technology and public health has been extraordinary. So we've seen the use of mobiles in tracking medicines and drugs for stockouts. So when a woman, especially for family planning and reproductive health programs, so if a woman goes to a clinic and that clinic doesn't have supplies and commodities on hand, that she's able to send a text message or be able to do a IVRS, interactive voice response system, to actually report that that clinic or facility doesn't have the commodities and supplies that she needs at the time that it's needed. So there's a number of crowdsourced applications from Ushahidi and these open platforms, so that when a woman in the rural area gets to the facility and sends that report, it actually shows up automatically on a GIS map, and then you can actually be able to track which clinics and facilities don't have commodities. But the part that's missing in many of these technology efforts is the action feedback, meaning she's reported that there isn't commodities, or they reported that there isn't drugs at the clinic when they went to pick it up. But what they really are reporting is because they want action. They want that engagement, that someone will do something about it. So it's great that technology, especially the crowdsourcing, can allow us to map that data and you have that information. But what's more important is to be able to provide that feedback to the woman at the time that says, yes, the next day or soon after that, that clinic or facility now will have commodities that at the district level or at the ministry level that they're able to provide the commodities that's needed that's been reported. So that way that there's action taken. So we've seen mobile health apps being used in gender-based violence and orphans and vulnerable children programs. Mobile money is very popular right now because you'll be able to pay beneficiaries. We do that in our programs. We use mobile money when we hold the training and people attend the training session. We don't give the remuneration in cash. We transfer it by mobile money. And that helps reduce the cost, and we do it at the end of the day. So typically what happens in some of the trainings, people will show up and then leave at lunchtime. So what we'll do is we'll after they sign in, they won't receive their remuneration until 5 p.m. or at the close of training or at the end of the week. So we've been able to use these technologies to really enhance what's already been going on as a project and program, and especially in public health. I see that hopefully even more.
I just have a slightly different question for Radharani. It's about coming from BBC, which is a hardcore media house, and we know that from I myself working with the journalist, I know that health beat comes at the priority level 8th or 9th in any newsroom in any given day. So, like, how did BBC turned out, like, thinking about working for health, going for an innovation, going for reaching out mothers, and using this kind of, media and communication, they have a lot more they can give back to the community. So why health? Why this thing?
Okay, so let me just clarify that although BBC Media Action is part of BBC Global News, we are BBC's international charity arm, development communication arm. So we are not a bunch of journalists, and what we really do is a plethora of things. We do communication. So, in India, we would be doing communication which would involve a very 360-degree integrated approach, whereas in, say, in another country like in Africa, we might be helping government networks or private networks to set up television and radio stations. So our range of work is quite diverse. Just to come back to what the context over here, so we are not really funded by the BBC. We work on projects that are funded by private foundations and multilateral bodies and governments, so on and so forth. And the project that I'm talking about is this big family health project in Bihar, which is funded by the Bill and Melinda Gates Foundation. And I think the reason BBC set BBC Media Action up about 13 years ago is simply because of this, that as one of the world's most respected and largest media entities, we felt that we indeed had to give something back, and so today, 13 years on, we are now working in 24 countries around the world with very different kinds of projects in each country. And the themes that we work on are health, governance, and resilience, with, of course, cross-cutting themes such as livelihood and gender. So given that background, what we bring to the table is when you're working on something as complex as this 1,000-day window, and you really have to, through your work, improve knowledge, change attitudes, affect self-efficacy, social norms, finally all of which, or a combination of which, can lead to sustained behavior change. Then you can't just work on one platform, particularly in places like Bihar, where our audiences are largely rural, marginalized, often media dark. So therein you have the paradox that a media organization trying to reach media dark audiences, and that's where I think mHealth for us became the solution. So we were not in it for mHealth. mHealth was an answer, like I said, to the problem.
Which came out after redefining the question within the context.
After redefining the question, after doing a very large media and mobile landscaping study, because you see, we knew that one of the things that had seen phenomenal growth in our country, and in fact in Bihar, because I think 4 years back, we saw the percentage of growth of mobile telephony was the highest in the state of Bihar, where large swaths of population not only live in media dark areas, but even when they have access to TV and radio, they're often without electricity. So how do you reach scale? How do you reach audiences who most need your need communication? So that's how we reached this solution of doing a couple of services for the frontline health workers. And just a month and a half back, we have also launched a mobile health service for the families, for pregnant families as well.
So mostly what I can see is from the Bihar experience, it's within the 1,000 days window, where we say the window of opportunity. But when we come back to Arogya World's project, it's more of a preventive aspect. It's like a life course approach for dealing out a non-communicable disease like type 2 diabetes. And so and both of the program used mobile technology. So if I put it in a way, so if it's type 2 diabetes and that's maternal health, and they used Bobby sitting in the middle, mobile technology in there. So the way we sat here is also the way we are, the programs has been set up. So how different it was, because Radharani was saying something about the using a 1,000 days window. So that gives a definite window of formulating the messages and the target groups. But whereas we talk about type 2 diabetes, it's like for women, for men, for children, for all these people, different messages. And at the same time, it's only if you give too many messages to a group of people, there is a chance for getting the message diluted. So it's just, I'm not a communication person per se, like expert. So how do you say or solve that problem?
Right, definitely great question. And there are very specific, well thought out lines of ideation that went through this whole thing. But two things. One is the process of what messages to create and how to send it in what order. And the other is the problem of technology itself, where sometimes when you're trying to, and this came up when we were trying to evaluate post the intervention, and suddenly we would see that, oh, this person has dumped the SIM card somewhere, and or this person has decided that the phone belongs to somebody else now. So you're like, well, you were the one we surveyed 6 months ago, and now you're the one I'm serving 6 months later, but you're not the same person. So I don't know, are you the diabetic, or are you the one who said your family is diabetic? I don't know who the person. So there were some of these issues. But in terms of creating the content itself, there is a whole model, a trans-theoretical model approach of behavior change, which really looks at the different stages of change that people go through in terms of contemplation and behavior change. And people do cycle through this process. So the idea behind sending these messages out was that it should be action-oriented, and it should be in a defined pattern of medical, then lifestyle, then something else, and then we had like four, and health. So we had like 4 categories of messages which went in an orderly fashion. So a person was not getting too much. It was only twice a week, so you're not bombarded. But we did do the check. We did a small check with a small group of people before we started blasting out to 1 million. So we actually checked to understand from consumers, did they think it was actionable? Did they think it was meaningful? Did they think that they would want to share it with others? Did you understand the messages, particularly in other languages, where and we back translated to make sure that the translation itself meant the same message that was going out. So that was in and of itself a challenge, and that's the whole process of making sure that mHealth, the health part of it is actually getting to the consumers. So there are other programs using the same theoretical model of behavior change, like Text to Quit. And I think there are other smoking cessation programs which have been implemented very successfully using, and if you go into the mHealth Alliance group website, you'll find a lot more of these initiatives out there as well. I think you can speak to the mHealth Alliance group as well. So.
Thank you. Yeah, there's a lot of pilot projects around BCC, mobile BCC programs, and some of them I think are very effective, and others require some evaluation as to its effectiveness. The mHealth Alliance and others are pursuing that type of evaluation. So there's a landmark study that was done in Kenya with regards to what's the optimal number, it was an RCT that was done, number of SMS messages, reminders that you should send a patient on a weekly basis in order for them to affect change, to be able to pick up their drugs or meds. And I believe that at the end, their conclusion was around 1 to 2 messages per week. But women tended to prefer the voice and interactive voice response or hearing from a nurse rather than just a text message. And why that's important is because there still needs to be that human element in terms of helping the behavior change. We ran a program of male circumcision, and the project managers approached me, said, Bobby, we have to circumcise 100,000 males within 1 year. Can we use SMS and mobile to do that? And my reply was very succinct. I don't know of any SMS message that would cause the target population of teenage boys and men to go to a clinic to get circumcised. You know, it's not appropriate interventions that for every public health issue. It has to be multiple modalities of reaching out, peer support. So what we've seen now is an increase in, for example, what they call mobile gamings for health, where they use mobile phone games as a part of the behavior change to provide education on the mobile phone. And we started seeing, and there's a few studies out now that are starting to see change based on the mobile gaming technology. In education, we're seeing some evaluations that are producing some good results as well. But it all requires a rigorous study. So that's why I'm very impressed with the M&E part that you've done in your study as well. Because many of the mobile health programs, they declare success, they call it sustainable, and then their funding runs out, and then you go visit, and the program is no longer working. So what we've seen, and it's a few examples, patient reminders. If you set up a clinic to send out a patient reminder, who's paying for the airtime for the clinics to send out those reminders on a daily basis? Once your grant runs out, once your funding is no longer there, once you're not, if that airtime for the SMS messages or the USSD messages aren't embedded as part of the clinic's annual budget, then as soon as your program, as soon as you leave, they won't use it. And we've done studies and evaluations and follow-up that we're managing about 2,500 antenatal care and PTCC sites today. And we've seen this consistently from other NGO and other groups. So that's why, again, I'm just cautioning about the sustainability part should be thought of first before people begin to think about how to implement an mHealth project.
Yeah, actually Bobby has been very polite. In the mHealth sector, the phenomena that both of us have talked about is called pilotitis. Yeah. So I think, Shushmita, if I can just very briefly describe the services, it would contextualize and help you understand better. One of our services, the first service is Mobile Academy, which is completely IVR based, interactive voice response. The frontline health worker, the community health worker, has to dial a short code and get registered, and it is then a series of lessons that she hears on her mobile phone when she calls that number, and the entire training manual has been broken up into 9 chapters. Each chapter has 4 lessons, and at the end of each chapter there's a little quiz that she can play. The whole service is bookmarked. So for example, if I'm a community health worker and I've done, say, the first 2 chapters, and then my husband is calling me to cook, to make chapatis, I can I can ring off, and when I get back, I start with lesson 3 of chapter 1. What we did was that the structure and the technicality or the app is not the most important thing. When you're reaching out to community health workers who have so far felt that we are just cogs in the wheel, they are pretty demotivated, and we are trying to sort of motivate them to, you know, really refresh and retrain them. It's important also to make the content rich and very appealing. And also credible. So we have created a character called Dr. Anita, and Dr. Anita is the voice. She's a kind, patient, yet authoritative person, a character, and she speaks to them. We started training the community health workers at about 38,600 and something. So far, we've had 32,000 unique users of Mobile Academy, and 4.2 million minutes of content played, and 16,600 community health workers have graduated, because when they complete the entire course, they get a certificate of graduation from the government of Bihar. Mobile Academy is a service that they have to pay for, and we did 3 rounds of user testing before we designed Mobile Academy and the next service. So we tested everything from what they were willing to pay, usability, navigation, and of course content. What speaks to them, what kind of language should the service be written in, the voice casting, everything, and a lot of localization. The second service is one called Mobile Kunji, which is the toolkit, which is essentially a deck of cards on a ring. They're a deck of cards made of credit card material, and it's got 40 cards, 2 introductory, 2 concluding, and 36 cards in the middle. Each card has each card speaks about something, and it takes the continuum of care approach. So we start at the beginning when a woman becomes pregnant. So the card has 2 sides. On top there's a conversation starter. So the community health worker knows that if she's going into the courtyard of a house and the woman is about to give birth and she needs to talk about, cord care or institutional delivery or birth preparedness, she knows how to start the conversation. There's a vivid illustration that either demonstrates the benefit or what she should be doing. There's a kind of a bridge, and on the back of the card are bullet points that they depict the things that she has to talk about. And the unique thing in this is each and every card has a unique short code. So after she has shown the card and has talked about that particular issue, she can call that short code and make the family listen to Dr. Anita talking about the same thing. So on Mobile Kunji, we've had 113,000 unique users and 3.8 million minutes. Mobile Kunji is a service where for the first few months the project has paid for airtime, but the reason why we call it scalable is then it's just taken over by the government of Bihar, which is where we are at. We are transitioning to government of Bihar, taking over this cost. And one of the other things on scalability, and Bobby, this should speak to you, is that we said that we really have to make this very affordable. So we negotiated one of the lowest call rates in the world. It's 50 paisa, which with the way the rupee is going up, I don't know, I'm very bad at math, I don't quite know what is it in terms of dollars, but it's which is the lowest rate in India. And it's also, we have, as BBC, we also have to be, there are BBC editorial guidelines, so something has to be, a service has to be open to all subscribers, and so we have We have tied up with Airtel, Vodafone, Reliance, Tata, Idea, and we are just signing our contract with BSNL next week. So we've really covered more than 95% of the market. So, so those are the two things that speak to anti-pilotitis. And the third service that we have just launched, which is meant for the families, is called Kilkari, which means Happy Babies Gurgle. And these are a series of time-appropriate weekly messages, one message per week, that again a family can register and they have to pay and they can get it. So it's really like babycenter.com for rural, families in rural Bihar. And it's just taken off. So I don't yet have numbers, but we've so far had about 26,000 registrations. Whether they'll continue or not, we don't yet know. It's too early to say.
So why don't we just move to, I know we have learned wonderful stories and wonderful lessons and projects. So how about we go to the audience and see if they have any questions, and then we can come back to the panel here. Any question from the audience? Yeah, of course.
If I can ask a few questions of the audience. How many people are mobile applications developers? Can you just raise? Okay, excellent. How many people currently have a mobile project that they're managing or using today? Anyone? Okay, a few, great. So my question to each of you then is, a few years ago, maybe 5 or 6 years ago, we did a mobile survey of community health workers. This is a real scenario. 1,000 community health workers attended our training, and the Ministry of Family Health and Welfare wanted to know how effective was the training. What did the community people, the CHVs, what did they learn? So they said, please send out a mobile survey and with 2 questions, only 2 questions. The first question is, are you using the tool from the training? And the person is supposed to reply yes or no. They can reply yes or no, just yes or no. And the second question is, in which district do you work? Because they wanted to know the geographic reach. Those were the only 2 questions. If you answered both questions, the recipients receive 100 rupee airtime as a thank you for answering those 2 simple questions. So when we launched the mobile survey, we were very excited. Sent out the 2 questions to 1,000 community health volunteers. The responses we received was, please call me back. My phone is turned off. What do you want? Who are you? Why are you calling me? So we received, because we use the Frontline SMS, one of the open databases, so you can track the responses that everyone sends you. The question is, again, put yourself in the position of a program manager. So someone has now spent their airtime responding to you, and they responded with bad data, poor data quality. They didn't respond with what you wanted. My question I pose to you is, do you reimburse them for airtime or not?
Gentleman here, working with mobile project.
Yeah, and thank you. I'm Vivi Rao. Basically, I'm an activist working in Andhra Pradesh. We are working with the Andhra Pradesh government family welfare project, where we are just trying to get the information about the efficiency of the primary health centers working in Andhra Pradesh. This has been a problem for the last 2 governments, where they have spent enormous amount of on the welfare projects, but when you look at the feedback or the efficiency side, it has been very low. So now we are trying to get some alternative methods of improving the efficiency. So we are just in search of finding out tools like what you have just trying to explain. And I would just like to ask you if you can develop some tools basically for the primary health centers across the state, which they have already huge number of family welfare employees are still existing there, and lot of money is spent on them, but the feedback mechanism or the response mechanism is very poor. And there, can you just give us some suggestions? And our government is ready to spend money on this. This is what an interesting side for you.
Okay, so I guess to answer your question, no, if I was a program manager, I wouldn't reimburse them. No, because that wasn't the answer I was looking for. So I'm not sure we got the answer from here, but he asked them. Yeah, please.
Actually, if the question that you posed in terms of whether you should reimburse the money or not, whether it was made clear whether the answer is relevant and the answer is right, only then you reimburse, and you should reimburse it, irrespective of, because if you ask a stupid question, you'll get a stupid answer. So that's the most fundamental thing. One of the things that I'd like to really share with our experience in the mobile health space is to use the technology by co-creative learning. That means you do not create any learning material and impose it on people who don't, whose behavior you want to change. You rather co-create the learning material with them. And if you do that, the impact is very, very strong. And that I say with a confidence in 40 different countries where the systems that we've been developing have been implemented. What it actually means is really reaching out to the people who are really affected by some of these challenges, and how they themselves create the material for their community. So it becomes a community approach rather than an approach in which you are superimposing something from outside and trying to. So you can probably facilitate that whole process rather than. I have been in the e-learning space for a long time, been an innovator, trained 35,000 professionals, and the reason why we've been able to reach out very deep into different this thing is that we work with the particular problem and work with the actual stakeholders and try to really kind of get that input into this thing. In mobile, it is all the more easier to really do it if you really take a very structured approach.
I think you really hit the nail on its head, and I'd like to share one of the challenges we faced. So when we did our 2 rounds of user testing actually, when we were developing Mobile Kunji and Mobile Academy, I think the going was much smoother. So yes, we had some challenges with language issues because, you know, within the state of Bihar, there are 4 dialects that are alive and kicking. So how do you then create a language that is easily understood by all? So there were like peculiar challenges, you know. So what we did was, through our 2 rounds of user testing and through a lot of immersion, we created a sort of a mishmash which had, flavor of Bhojpuri, Maithili, Maghi. So that was easily understood by the community health workers wherever we went in Bihar. And it was smoother sailing, and we felt, oh, this is actually not very difficult. So we learned that, okay, fine, if you're talking to a community health worker, this is the way you should be talking about spacing, or this is the way you should be talking about the 6 clean things that you have to keep at home if in case you go in for a home delivery. Or this is the way, you know, this is the language, or these are the things that you have to flag off if you want to talk about recognizing danger signs just after delivery or in a newborn, etc., etc. So we were very gung-ho when we went in creating content for our round, the first round of user testing for Kilkari, which is a service based for families. And I cannot tell you how challenging it was, because when you're trying to create material, create content for a frontline health worker, community health worker, obviously a community health worker is a little more educated. She's also a professional. So we had to then go in for 4 rounds of user testing to get our content for Kilkari right. You know, so for example, swasth, which is a word for health, is not understood by families. you know. So what do you say? So not just language, but the way. So we kind of call it localizing content, you know. What kind of inflection should be used in the voice? What is the length of a sentence? How long should the capsule be? Because, you know, then they run out of patience. Their attention spans are very short. You know, so how do you get around talking about a certain thing? So, for example, if a Kilkari message is going out just the last week of pregnancy, how do you talk about that particular message? In what fashion, so that it is much more identifiable and people empathize with it? So I absolutely agree. You know, we were just, it was like, you know, you guys go back and just do it all over again. You don't know anything. So, you know, our confidence was completely, absolutely broken down into little bits, and we learnt the hard way, but we did not give up. So we had to really find the budget for doing 2 more rounds of user testing, because at the end of that second round, we were nowhere.
So how was the case for you for developing that thing? Because this was maternal child health, user testing, going through the community, but you are going straight to the clients itself. So for you developing the messages, how tough it was, or how difficult it was?
I would say not difficult, but because developing was not, we were developing it from a very theoretical perspective first. The first round was easy because we could get the information on the internet, and we could work with Emory University and get all the information and create all the messages. That was very easy. But when the rubber meets the road, they're like, what is, how much are you going to bombard me with all this information? Who wants to listen to this like day in and day out kind of thing? So it's this whole concept of co-creation that I think you just mentioned, that it's very important. When we took all these messages and we took it to the real consumers and asked, now we sat face to face with them and went message by message saying, does it make sense? Now what else should we say? Because some of the messages were very Western in its outlook and was probably tailored towards a very clinical trial perspective. It was
Okay, that was something. That has nothing to do with our session, I suppose.
testing. The first was just to understand that the messages were understood. And we came back with a lot of questions and a lot of differences.
So sorry, let's go back.
So like you said, even with this, we had the same issues. So then after the first round of testing, we went back to recraft the messages. And then we took it to a second round where we actually took by message and said, asked the consumers, did you receive this message? What do you think? And we had a series of questions to really understand what they thought of it and how would it impact them, and really had a very detailed set of questions. But then what we did in the second round was we actually categorized the messages to say that did this actually reflect health, and does this reflect lifestyle or eating habits and things, so that it was easier for us to analyze what should be the content coming out of it after learning, after getting all the consumer feedback. Because we again went 30 consumers per message, so it was a lot of information that we had to cull through. And after that, we then did again another translation and a back translation to make sure that the language was correct. And even after that, I think we still found like 1 or 2, just when we were going through it ourselves, we said, oh my God, this word, is it sounding right or not? And then again, that was the third round of it. And then when we went to the actual questionnaire design in terms of which I keep harping upon is the measurement and evaluation, is that it's so critical that when we ask the question, we ask it in the right fashion. And what is it that we're asking? Like you said, garbage in, garbage out, that's it. So even the questions which we translated and gave it to the moderators to ask, we said, please make it common language. Don't translate it as if you were translating into, like, you know, some Harivansh Rai Bachchan textbook or something like that. Please, it has to be very common. It has to be language that people understand in all of the 11 languages. So there were a lot of challenges along the way, but then now we've got the data back, and we're looking at some good results, good trends, and just because the other group also just published before us, we feel good that yes, this is a good, effective way. But then again, the big challenge is how do you now take it to everybody who does not have a Nokia phone? This was very Nokia specific, and these consumers had opted in for the Nokia platform. But if you went an open source, how can you develop an app or something that can go out to everybody? And so we're not like really, we're not vendor locked in that sense. So that we don't want to say that, this project is only operable in the Nokia setting. It should go to everybody. So those are the other next challenges that we are facing
I
now.
actually have a question for Bobby. Is that once we from public health arena, once we come up with a project like this, we have like so many messages we want to give to the audiences, and there are like 3,000 things we want to say, and we want to say it in a 5,000 millions of ways, and it's like so many things we want to test. And every time, like we all were saying that, we find out a way, like Swasth. After the first round, it seemed a brilliant idea to use the word Swasth, and at the same time, maybe after the third round, it didn't seem as brilliant as the first round. So, and using this. I'm not a technical person, but I've been told by my technical team is that every time you want to change it, we cannot it's not Control X or Control Z kind of a thing, the way we do it in our laptop or our MacBook. So how difficult it's for you for a technology perspective, like every time we change our laundry list?
So in the public health side, especially at the primary health centers, and I'd like to follow up on your question. First, there are good ways to get feedback. However, I haven't seen in any of the programs that we manage achieving 100 or even 90%. If we can get 40, 50%, we're in terms of feedback, we're successful. So, but I'd like to talk to you about some specific ones that I think interventions that I think would help. As far as the different technologies. Again, if you remember the case I started off in the beginning, how it's very easy just to download the software and get started. But what happens once you get started is, especially at a community clinic or a antenatal care, is that the data collection form, the indicators, data collection form that you started off with in the first year of a project, by the time your 5th year, it has changed. So data collection forms change. The indicators that you want to collect against from the time you start in year 1 to the time that you finish in year 5, those have changed. So the indicators change, the data collection forms change, and then the reports that you want the community health workers, the primary health care centers, and the district officers to report on, those change as well. So what that means is trying to select a technology or a solution or a platform that allows the form to change, the indicators to change, and the report to change without having to rechange the software. That you're able to, so there's a number of some free tools out there that allow that to happen across a number of mobile phones, but there's some challenges, and here are a few challenges. So we've done some programs where we've used a simple SMS data collection, because you can send a number of women who tested positive, number of children who are visited the clinic very easily, just send a 1 or a 0 in a format. But when it comes to a survey or any in-depth data collection report, that's when you need a form on a phone to be able to do skip patterns. So if you're diabetic, then I'm going to ask you these questions. If you're not, I'll skip and ask these other questions. So the complexity becomes increased because when you first set up the program, you first set up the software, you have to think about that the questions that you're going to be asking, will change. And so trying to find a way to select a solution that you can change it yourself without having any IT or programmers or any of those folks involved. And that's hard to do. I mean, there's a number of tools out there, but that's the approach that we've recommended and have taken, is where you have more control to set up the numerators and the denominators and be able to create those indicators, because the indicators you're collecting today will change tomorrow. And you don't want to go back to the mobile application programming team to say, okay, now we have this new indicator, please program it into the system, and now please replicate that back out to the old, So there's a number of new tools that are out there that we've been using that allow just the NGO programs themselves to change the indicators and change the forms. Excellent idea around testing, but I would like to caution one thing about the co-learning that we have experienced on the ground level, which is a lot of programs actually believe in developing their applications with the users. So in our case, it's the nurses, the clinicians. But what we've seen is there's very siloed and vertical programs. So a HIV person program will go to the nurse, they'll take her time and say, okay, we're going to work with you to develop a mobile app around HIV data collection. Then the antenatal care person comes in because they have a vertical program. They go to that same nurse and say, we're going to develop a mobile app specifically for you around antenatal care collection, labor and delivery, those sort of things. Then the TB program comes in to that same nurse and says, we're going to develop this TB surveillance information collection system. We want your input. And so what we've seen is a proliferation of many of within the vertical programs within a single primary health center, all using text messaging, SMS messaging, and the nurse, she has 3 different phones. The pharmacy has 3 different phone apps. The stock clinics, there isn't, what we'd like to recommend is having a much more structured approach to all the vertical programs, where if someone's already collected a data, if you've already collected a question with your SMS message, that I can reuse that instead of me asking that same question from that same nurse or that same patient. So I'd like to sort of extend your co-learning, but make it more broader. That says having the integration of the vertical programs, because that's what we're seeing happening more and more as people begin to embrace the M-Health and M-Education and these programs. So that's what we've seen as well, is that 3 or 4 different projects and programs, all within the primary health center, all reaching out to the community health worker. Again, many of the tools right now that I'm aware of, so Damagi has an excellent ComCare, as an excellent community project for community health workers, but they do the same. They develop their application around the community health worker together. Everyone does that. But in the e-learning, what we're also seeing is a push towards doing e-learning on the phones, and especially for the smartphones, and the massively open courses. So we're starting to see more proliferation on the technology side. For example, Harvard and MIT now are offering a degree program as part of their MMOC courses. So what we're seeing is, in terms of the e-learning space, it's becoming very crowded with people who are offering the technology side, but not so much, the really good content for free, or making the content widely available at the local level in an offline manner. So that's the other thing we're advocating, is that a lot of these, first, especially for mobile and these other ICT applications, have to work without internet, that they have to work without depending on a server or some cloud solution. It could be occasionally connected cloud, but it has to work without any of the technology. It has to work in a disconnected mode. And so that way, so we partnered actually with Intel. Intel has a free software, but what they do is, and we worked with them, is as people get certified in the content, and it's reproductive health, and they go through, and one's reproductive health and one is lab. We're trying to train lab technicians. But after they finish the course, the e-learning course, on the inexpensive $100 netbook that's a solar-powered netbook. So on the back of the netbook, I have a picture, it's a solar panel so they can recharge it in the field. But after they complete that certification, or the e-learning, they actually can keep the netbook itself. So it's an incentive for them not to just finish the course and the training, but that they can have ownership over the hardware. So, you know, we believe in having private partners participate in the development and design of some of these systems. So at the end, when I've completed the community health worker training, I'm also training some small IT companies along the way that will provide support to the hospital, the clinic, and we're no longer there. That the local IT company, or the local, usually it's a really small little computer training center, are the ones who are recipients of the content, they're recipients of the e-learning, and they're the ones who are continuing the sustainability even though we're not there anymore. So that's the other aspect that we've tried to infuse in terms of co-learning and sustainability is to have a broad view of having other people involved, not just our project and program when we're doing the co-learning and co-development of the software.
Wonderful thoughts. We are actually running out of time because of the next session that will be. So if the audience has no more questions, I would like to, if there is anything from the audience. Okay, then I would like to request the panel just to set the last finishing words or your words of wisdom to the audience.
Arogya World being successful was that Nokia was in it with us, and it serendipitously happened to be that, you know, they had a huge database of consumers and we used what was available already. But to start developing and going about it, you absolutely need more of the public-private partnerships to come into place, and these kinds of forums are good to meet and network and sort of understand who you can lean on and how we can create these partnerships going forward. So I think that I would close with that.
I'd just like to thank each of you for attending and listening to the session. My sort of takeaway is that, you know, really to embrace mHealth and the technology, but it's, as I mentioned in the beginning, the technology is just the modality, just the tool. Please emphasize the end user, the people actually are going to use it 5, 10, 6, 7 years after you've developed your fantastic software, to keep them in mind.
I think my take on all this is that, our take actually, is that when you work on a project which is as complex as the one we're working on now, multi-audience, multi-themes within this 1000-day window, I think mHealth or the use of mobile phones is just one way. I mean, it is really using a completely integrated approach, a combination of mass media, interpersonal communication, community mobilization, and technology that can ultimately help one to achieve one's end goal, which is creating a mediating and multiplying effect of talking not just to the women and the community health workers, but also the social structure around them. Because I think, just talking through the mobile phone is not going to help solve your problem. That's one. And the second thing is, again, just to underscore what you said just now, we have to think of ideas, because I think technology, the beginning of technology is, so we have to think of ideas that have a life beyond the life of the project. So these are the two very important lessons that we have learned. And the two mantras really.
Yeah, with this note, would like to say from my end is that what my take from this 2 days conference or for this session is again, it's ICT, mobile, e-health, social media, internet, whatever you say, it's just the modality. So we can make a change if we really want to make a change, and this is one of the faster way of reaching the people. So with that note, I would like to request you all for a round of applause for our panel. So thank you so much for being with us.
And it is good to sit in the back bench, and backbenchers are always more smarter than the front benchers. But can I request them to be obliging and come forward a little? Because perhaps we don't have enough people to fill all the seats. Thank you for coming inside. This is the last session that we are into, and this session is especially made for post-lunch session, to not to think about the food that you have eaten, but more about what you're going to talk and listen. This is a rapid-fire kind of session, and it is called Hayaku. I don't know the meaning of Hayaku, but all I know is that what is going to happen, and what is going to happen is there are about 7 speakers, and they are going to speak for 5 minutes strictly. And they have 15 slides. Each slide is automated to flip over in 20 seconds. So that's how it is. So there is a challenge between the slides and the speakers. So they have to speak according to the slide, and they have to speak for 5 minutes. That's the format. And we have a dear colleague here called Megan McGill, Assistant Information Officer. She will take them all through. I'm not taking the name of all of them because she will introduce all of them. And I will wrap it up at the end of it, and that is how we are going to end the day. So Megan.
Hi everybody. How's it been the past 2 days? Good? Great. Okay, well, we're ready for the grand finale. We're going to hear from about 7 speakers, as Osama said. And we're going to get started with Mr. Nima Sharing, who is the former assistant to His Majesty, the King of Bhutan. Okay, Nima, ready?
Imagine a bridge between the past and the present. Bhutan is that bridge. We came straight from the agricultural revolution of the 19th century to the information revolution of 21st century, bypassing the industrial revolution of the 20th century. We measure progress in terms of gross national happiness. In 2008, we became one of the world's youngest democracy, and with the becoming of democracy, the use of social media started in Bhutan, but more so through anonymous blogging, anonymous website, partly because we have a respect for the culture. Open criticism was not a norm. So in 2013, with the second parliamentary election, the use of social media becomes more intense. There was a website called bhutanamis.com. It became more and more critical. At one point, it got censored. And people thought that the government of Bhutan censored it. Maybe not, maybe. But people moved to the Facebook with a sense of humor. One of my favorite movie, The Sholay. I did not make this. The Amjad Khan, the Gabbar Singh, the former prime minister, photoshopped, and then we have the Dharminder, the former opposition leader, as the challenger. We have the smallest opposition in the world and one of the big majority. With that, they use these photos to send a message that the ruling government was the government of the elite, with the Prados and Land Cruisers. They say, who wants a Prado? Raise your hand. And those masses are not eligible for Prado. This picture went viral. And with that picture, more and more it started demanding change. It's not that the former government was bad, it was good, but in Bhutan we say because we are small, good is the enemy of great. So more and more people started using anonymously Facebook, and some started commenting openly. And with that, the change, more and more people voted for change, and whom they picked? A person, a politician, MP, who started the blogging when he became MP. The former opposition leader, he was the first politician to use blog. And he was with every citizen blogging. And he was blogging on the street, and he became the current Prime Minister of Bhutan with a new set of cabinet. Totally unexpected, totally unexpected. A blogger become the new Prime Minister of Bhutan. And we thought that future of Bhutan lies, or future of democracy in Bhutan lies in the hands of the citizen. It should be that way, and not in anybody's hand. And not only politics, even the youth started using social media, be in the Facebook, elsewhere, where they organize street fashion. You know, you don't need the resources. You bring the fashion from the street to the social media and organize it. When you organize it, you are big. Youth, there is a organized called Go Youth Go, and they say one youth can make a difference, everyone should try. And the way they do is they use social media to organize it. And this is how, in a small society, when you organize, you become big. Not only that, even more and more social commerce, e-commerce, some people started using the social media sites to connect the buyer and seller, trying to cut the middleman between. So this is a trend that you see in Bhutan, though we may be the last country to get connected to the internet, it is still moving forward. There's a knowledge sharing, the writers group association on the social media using the sharing of the books, sharing of the knowledge, research, advising, mentoring. So all those groups, especially for a small society, and it's easier in Bhutan because many people on the online, you also know offline, a small society. And you have a group here, the crowdsourcing, fundraising. Last year, one of the most important historic fort got burned. Within 1 hour, 28,000 Facebook group. 28,000 is a huge number in Bhutan, where 1%, 2% is a huge number. Social media is especially powerful for women, because women in general are usually introvert. They don't come out and speak, but they are very powerful in the social media sphere. It's a great tool for them to inspire each other, to inspire leadership. And we have not only that, social media breaks down the barrier, breaks down the nationality, cross-cultural. It will help us to improve our life, our community's life, our country's life, and whole of South Asia. Thank you very much.
Wonderful. Well, it sounds like there's been a lot of progress for Bhutan, both with transparency in politics, economics, and for empowering women. Our next speaker is Mr. Shahab Shamir. He's the president of Bangladesh Youth Environmental Initiative.
Thank you very much. I will make an attempt to show you the landscape of the social media and the ICT in Bangladesh. So the first computer used in Bangladesh back in 1970s in the Atomic Energy Commission of Bangladesh, and the use of internet and actually social media didn't get the momentum until 2000 or 2001. So currently the number of internet users in Bangladesh is around 35 million, and out of which is, I think, around 20 million is actually on Facebook. And the picture, actually, this is a very interesting picture. It's actually during the rainy season in southern part of Bangladesh get flooded, and most of the schools have to be closed down. So this is actually mobile school, which use boat equipped with the solar panel and the computers inside the boat, and they actually go house to house and teach the students during the rainy season. And recently there is a big uprising in Bangladesh called Shahbag movement. Millions of actually young people together to protest against some verdict given by our ICT, it's an International Criminal Court. So actually young people heavily relied on using the Twitter and Facebook to mobilize to get together and protest. And this is actually another revolution that's by the religious groups. In terms of number, this to be higher than the earlier one. And since they didn't have actually much voice in the mainstream media, so what they actually did, they resorted to the social media platform to mobilize their populations. So I'm sure many of you heard about the garments factory collapse in Bangladesh, and the civil society actually reached out to other people. And the first thing I got to know about this incident, I was out of Dhaka in a very remote places for some work purposes, and I got to know about actually from the Facebook that this something happened, and many people started tweeting it and Facebook it, and they rushed to the spot and take part in the rescue operations. And many people considered civil society was more active than the government in taking part in the rescue operations. So this is another picture of showing the Grameen, the village women are trained with some ICT and technology, and then they actually reach out to go to door and give different healthcare services to the people of that in the remote places of Bangladesh. And this is a customized, very specialized mobile phones that there's an organization called Empower that uses actually to take pictures of the different diseases that village people go through, and then they send this picture over internet to some specialized doctor that's sitting in the capital, and they actually give me prescription and medicine to those people. And this has been one of the very successful initiative in Bangladesh called Jago Schools. They teach the street kids, and they currently have around 1,000 students across 7 divisions of Bangladesh. One of the initiative was they actually put a computer in the middle of the slum, and in a customized computer, there's a different application that some kids actually can come and use that computer for different of the purposes and learn many things. And this I actually mentioned in one of the earlier session as well. This is a very recent small business enterprise that heavily use the social media platform to market their product, and recently they are actually setting up their showrooms around the country. And so these all some of the good uses that I mentioned, but it's not always positive as well. There are some concerns as well. Recently, the minority group, the Buddhist community in Bangladesh, their temples have been attacked and some vandalism has taken place, and it's all started from a picture that was posted in Facebook. Some got angered, and then they gathered other people and attacked those minority people. And recently there was someone, a university lecturer, make a comment and which actually in some way defamed the Prime Minister, and then some legal actions, and he was jailed for several months. And so there are some restrictions as well, and in regard to that, and then the officials, the government of Bangladesh actually banned the YouTube for a year or so, because they found it, the opposition group probably using it in a very negative way that goes against the government. So there are some real concerns as well. And recently some of the very popular bloggers who has a high number of subscribers in the online platform, actually they got arrested for writing something that actually hurt the sentiment of the religious people. So besides the positive things that I showed, there are some real concerns as well that's taking place in the social media landscapes in Bangladesh.
Thank you very much. Okay, our next speaker is Mr. Giresh Giri, a freelance journalist from Nepal.
Hello everybody. I'm going to tell you a story about a 19-year-old girl. She was an immigrant worker who worked 4 years in Saudi Arabia, and while she returned in Nepal, immigration caught her because she had false document, and then they detained her, and during her detention, the immigration officer took all the money, grabbed all the money from her earnings, and later on when she released from detention, that time a police has been told to escort her, and instead of taking straight to bus park, he took her to a hotel and raped her, and when she went to her home, it found she is pregnant, and then she told her family all details, and family came to Kathmandu, and at that time when the government was not serious, that time a loose group of Facebook and Twitter user, they formed a group called Occupy Baluatar. Baluatar means Prime Minister's residence, and they first put their petition for the Prime Minister in Facebook, and then they started coming in the street. It was front of the Prime Minister's residence, which is Baluatar, Occupy Baluatar, and mostly the girls, they started coming in the protest, and even the media, they come there, and then the women issues came over, and other different walks of life people, they went there, and there was signature campaign, thousands of people signed for the women's cause, and actually that girl was, why she used false document was, our government doesn't allow girls below 30 years to go to Saudi Arab for the work. So women, they are using other people's passport to get there. And some cartoonists like also started coming there, and they made spot cartoon, and this is the very place where every morning Prime Minister's motorcade used to pass. So it was very much effective, and and same time since our country was in in conflict for many years, and transition is prolonged, and there is no way out. So many cases of impunity was there. So other cases also came to the same spot. That venue became the voice, the place to raise the voice for voiceless people. Then they started coming for their against the impunity. And there was one case. This person was then Maoist lawmaker who was convicted by Supreme Court, and but he was never arrested. He was for life sentence. Supreme Court ordered for him, but never arrested, and he was everywhere in public. And sorry, there are some more. Yes, and he was never convicted. So this Occupy Baluwatar, they started making his poster, and they spread all over in the city, saying he is murderer. And then there was candle light as well. The Occupy Baluwatar started, where even later on, police, you can see the police woman lighting the candle there, and there was very good coverage. Even the editor of Broadsheet daily newspaper started coming there for the Occupy Baluwatar, and some creative activities used to be there. Some people used to protest with different forms, and sometimes there used to be dance and song as well. So people, they started getting there. All this type of advertisement were going out from Facebook and Twitter. It was like viral, it was flooded everywhere. And one day I found these people who gathered in Baluwatar and then came to the street, and they put the mask of different political leaders, and they started shouting like, I am the murderer, please arrest me, I am the corrupt. And later on, even the political party, at the end, they started getting there. He is the Politburo member of Communist Party, UML. He started getting, and he joined the hand with those Occupy Baluwatar people, and it became even more popular. And at the end, he is the chairman of Interim Ministerial Council. He called there was one more slide, but I cannot see. He called the Occupy Baluwatar people, and he formed a commission headed by a secretary of Prime Minister office, whose job was to review all the laws and all the things on laws and everything on women in Nepal. Before that, before the Baluwatar people went to Prime Minister office, they ordered to take action against even the Director General and Deputy Director General of Immigration Department, and they took action against all other culprits. Thank you very much.
Okay, great examples of social media for social change. And our next speaker is Mr. Abdullah Dayo, spokesperson for Progressive Youth Forum from Pakistan.
Thank you so much. So we are having the Hayaku presentation, in which I'll be, quickly telling you what social media is doing and what are the milestones achieved by the social media. It's automatic, or I have to. All right. I'm having too much time. Okay. So here starts. The starts begins from the political change. First, I mean, in the beginning, we were having very, little turnover of the voting, but due to the social media as the tool, we were able to encourage the young participants and the people who were having the internet facilities to get in, contact with the parties and do use their right to vote. And then this time, social media played again a very great role to engage the young people in the mainstream political process of the country. And now a big bulk of youth is getting engaged in the political process of the country and voting. After that, we used to have fights with the authorities through the dandas and the lathi charge and so on. But now we are having the SMS system through which we raise our concerns through SMS, and the frontline SMS is playing main role in it, and to mobilize the masses about any issue, any specific issue related to the violation of civil, political, cultural, and economic rights of the Pakistani people. And then last year we had a big bomb blast in Balochistan where more than around 300 people, they died, but government was not taking action. What people did, they went around the markets and so on. They asked the house owners, please switch on your Wi-Fi to make it free. And they tweeted, they were doing Facebooking, and finally government took the action, and the governor was removed from the Balochistan. And then he was the human rights defender. During that first bomb blast, he went to rescue the people, and suddenly second bomb blast took place and he also died. So what the civil society did, that we should have a portal on which there should be the protection of human rights defender through social media. So we are using Ushahidi to trace these issues. Then these are the local communities. These are the illiterate people who don't know how to read and write. But we provided them 3 months training on the usage of computer. So they are doing offline blogging in their respective villages. And then we connect those blogs with the government websites to know what is actually happening. And this is the entrepreneurship at local level. The middlemen, they used to take all the advantages. But now we are having Sughar Foundation, which is taking all the artwork to the international level. Now these products are not sold in the markets of South Asian region, but these are sold in the America and the Europe as well. So they are having direct advantage now. This is the Khoon Se Hai Zindagi kind of project in which what is done, that people they donate their bloods, and if you need a blood, you just have to SMS, drop a small SMS, and you will get many 30-40 people to come and donate the blood. And then this is the SMS tracking system. If then someone is, a pregnant lady, how to trace them out? The government has introduced the SMS tracking system for the ladies, in which the lady health workers, they go to the respective villages and they see how the health of mother and child. Yeah, in our country, we do have the corruption at the government level, where the authorities take corruption, but now the SMS system has been introduced. It's a free of cost. You have to send the SMS to the government authorities. If you are going for the driving license and you have to pay a bribe, they will take action. Then we use digital storytelling to combat many issues, not only the violence against women, but there are the issues through which we highlight the issues in Pakistan, and we engage the people to develop their stories digitally. And this is the Bas Karo kind of campaign, in which if you are the victim of sexual harassment or the violence, domestic violence, you will be you can report your issue through SMS, email, on Facebook, on Twitter, anyway, and you will be getting free legal aid. Then we are having a very Bites for All, a human rights organization focusing on the ICT kind of revolution in Pakistan. So they are running a campaign against the ban on YouTube in Pakistan and the privacy, internet privacy rights, and apart from this, the issues which are being violated against the right to freedom. Then we are having a mirror. It's a girl whose name is Aina. So she calls her mirror herself because she lives in Peshawar and she's not allowed to go outside of the house. So what she do, she makes these items while sitting at her home, and then she sells those items through Facebook. And now she's very famous in Pakistan and out of the Pakistan as well. Then we are having, how to increase bilateral relations with India and other regional countries. So these kind of social media melas and initiatives are being taking place through social media, through which we can, initiate the peace process within the countries and outside of the country. Thank you so much.
Great, thank you. I like the image of the SMS and the phones on the front lines. Okay, and our next speaker is Mr. N.K. Ashokbaran. He is Media and Publicity Secretary for Law Students Association of Sri Lanka.
Good evening, I'm Ashok, and I want to speak on social media in Sri Lanka. So I'll be speaking about how social media has evolved in Sri Lanka and what is happening now and how social media is perceived by people in Sri Lanka. So this is Sri Lanka, a small island, very beautiful island, naturally blessed. We got a lot of wildlife, beautiful beaches, tea estates, and we produce world's best tea, and we are proud of that. And you got to make it once to Sri Lanka to enjoy the beauty. But then, we also have this. We've been through a 30-year war, which has affected our people, and there is an ethnic conflict which still pertains in Sri Lanka. So this is also part of Sri Lanka, who we are. It's not just the beauty, but also the people suffering. So in this backdrop, there comes social media. Today, due to the war, Sri Lankans have gone around the world. And social media, at the start, it was like a contact point for people, for for your relatives who are living abroad to come closer. But then social media started evolving. And Sri Lanka today, I think, has put itself in the social media map of the world. The major use of social media started with news. There you see a coin. That is the legacy media, the print media, electronic media, showing one side of the coin. But there is always the other side of the coin. That is how the people started using social media. Every news had another side. And the people who didn't get space in the normal media started to use social media to speak out their voice. So it was all started with blogs. So people started writing blogs because they were not heard. They were not given chance in the legacy media. So blog was like an avenue for them to raise their voice. Why blogs became famous? Because there's no censorship. Then everyone started using. Because you write to a legacy media, there will be someone editing it. So your views are edited by someone else. But you don't want that to happen. So social media gave that space, gave that freedom for you to say whatever you wanted to say. So the legacy media won't publish whatever they want. Then came the Facebook and all these social networks started coming in, and people started making friends, and also people started making trouble. So we have to see the both sides of social media. Hate campaigns came up. It is still there. It's a major issue for us, hate campaigns. But the moderates in social media are somehow managing to get over that. They are also having a counter campaign, and they're somehow managing the situation. But then still, apart from Facebook, Twitter, Foursquare, YouTube, Flickr, and all these other social medias are also widely used. Especially even the commercial entities, the businesses are thinking about media. So this is the social media, and that is the legacy media, the print and electronic media. Today, the print and electronic media has understood that the social media is taking over, and they are handshaking with social media. Today, the Sri Lanka's leading newspapers and television services are using social media because they knew social media is the future. And this ground views, it's a Manthan Award-winning, the DEF's Manthan Award-winning citizens blog. It's very famous. From the most educated people, like the diplomats to the youngsters, they write in this. Most contemporary issues are discussed, debated in the comments, and it's a very good citizenship initiative happening. And today, the president of Sri Lanka has an official Twitter account verified. So far, he has not tweeted yet, but his staff is tweeting, and the president's secretary even organized a question and answer session. So even the authorities want to use this. The political parties are coming in. The political parties are well organized, and they are using it. Apart from having the virtual world relationship, we also organize a tweet up SL. It's like the tweeples, the people who tweet in Sri Lanka. They have a meeting. We get together on a day in a year, meet each other, see our real personas. Because all these days, we have been tweeting on our virtual life personas. This is the social media day. It was organized by with the Mashable. You may have heard a site called Mashable. The social media day, and this was also hosted. So the social media is picking up among youngsters. They are all passionate about it, and it is also having events like this. It encourages this thing. So Sri Lanka is still, I would say, in the third or fourth step in the step of social media. But we are improving, and people are looking seriously and taking social media seriously. Thank you.
Great, thank you very much. Okay, next we have Ms. Trupti Chengalath, Communications Head for Mahidi.org from Chennai, India. Oh, Bangalore. Just kidding.
Hi. India, like every brick in the wall, each of us is jagged, imperfect individually, completely unique, but every brick indispensable in order to stand. And something very important for us to understand is our context. The factors that contribute to our diversity also contributes to contradictions and opposing realities that exist, that coexist. And the same opposing realities exist in our social media landscape. That's a context we must remember. So, coming to the emerging youth with access to the world at their fingertips, you know, the instant gratification generation. We are impatient, we are demanding, and we want things to happen now. The generation that just simply cannot wait. This is a little cartoon. This is a crude illustration, but it's important to understand that this impatience is what is driving the space in social media for empowerment. Not only in India, I think across the world. It is this impatience that's actually pushing the youth, making sure that social media is a tool for rights, for movements. It's become a platform for the youth to actually take up a movement, take up an issue that they care about. And it's the youth that's actually snowballing all the movements that are happening right now in India. I'll wait. Okay, so the first campaign that I remember is the Pink Chaddi campaign. A very bold statement that was made where 40,000 women sent their lovely pink underwear to a Hindu fundamentalist group to make a statement, because the Hindu fundamentalist group said, "We hate pub-going women." And this was in 2009. Of course, social media is also used for discussions and debates. These are real-time experiences that people are sharing, instant opinions, dragging people out on the streets. These are not youth that are just sitting behind their screens. They're coming out onto the streets to have real conversations and real experiences. And of course, the fight against corruption was never louder. It was social media that really brought on a rapid movement. It was rapid in in how quickly it moved. And it also signified young and old people coming together to fight for something that they cared about. Signing petitions were never easier. You just have to sit and click. But it has actually made some change. There are facilities for the blind, availability of acid, and also a letter to a particular politician who to challenge them to survive on a ₹12 meal. Politics in India. Of course, politics in India, everybody's discussing it on Twitter, on whatever it might be. You're talking to your elected representatives, and in this election, social media is going to be another battlefield. If Obama can, so can we, right? The police, well, they're also interacting with public on the social media. They are listening to public grievances. They are giving out public service messages. Well, at least the traffic police, let's start with at least the traffic police, then we can get on with the rest. That's a crude message over there, but they're very nice. I don't know if Delhi has it, but Bangalore has it. There are organizations that are working with youth and activists in rural areas, giving them cameras in their hand, asking them to capture and to expose human rights violations and discriminations that happen in corners of society that we so conveniently try to forget. There are also other organizations that are going to people far beyond the cities, trying to train them, trying to get them onto the internet and get them to be part of the social media buzz. In this room itself, there are lots of us who are working on issues of that sort. Excuse me. There was no need to talk so fast. But here's the real challenge. When and how are we going to be able to replace the black slate with a gleaming tablet device and get this child also to be a digital native? It's going to happen. I believe it is. When and how, we'll just have to wait for it. That's my cue. Thank you.
Thank you. I think that was a wonderful reminder of how powerful social media is. And our final presenter is Mr. Abdul Rashid Ali. He's a lecturer for the Faculty of Arts, the Maldives National University from the Maldives.
Yeah, even in the beautiful Maldives, things happens. Actually, this is a photo that we just posted, and it's from the tourist resort. It's actually, I think it costs around $10,000 per night. Okay, this is a story about Shayana, who actually was born in Maldives with a birth defect on her face. It's her parents looking at the picture. Yeah, that's the birthmark. All over the face. Actually, the doctors said that, I'll tell you later what doctor said. She was born in Male Hospital, but then later, actually, we have to consult with, because this is her brother. She has got only one brother, elder brother, and he doesn't know what's happening to her actually. He was so happy to take a photograph with her. That's the doctor from Chennai, I think, and he was, I think that time he was in Male, and he was telling that she needs immediate help from abroad. Actually, in the Maldives, we don't have, very advanced medical facilities. That's why he wrote a certificate to send her abroad to see a plastic surgeon. But then they need money for this. They don't have any money. They are from a very poor family. So they don't have any money to go abroad and cure for her. So what they did was actually they used social media, Facebook. Opened a Facebook account and then said, "My beautiful face." And people started donating. And also the news appeared in different newspapers of the Maldives as well, because it's actually a very rare case in the Maldives, because we haven't seen such a birthmark before. Defected birthmark. And this news appeared in newspapers in other countries as well. This is a magazine from UK, England. So this is the police commissioner, and that's Shayana's father. And the police force, among themselves, they collected money, and they were donating 1,78,000 rupiah. That's around Indian, I think, 6 lakhs nearly. Yeah. Then that even was not enough. So what happened was that this was heard by MP, Mr. Ahmed Shyam, we call Sun Travel Shyam, and he was helping. So what he did was he sent them to Chennai for medical. So Shayana's mother and father flew to India, and that's her father. Actually, what he said was actually he will do whatever he can to save her life. Whenever he wants. That's her father and mother together with her. And it was the best picture I could actually got from the newspapers and blogs, and also from the radio stations. To make this story, I actually was collecting pictures from different sources. And these are actually kind of Facebook pages that I have collected, looking for different help from different people. One is having a heart problem, the other is having a lung disease. Thank you very much.
So what happened? Was she able to get the surgery? And yeah? Okay. We need to see an after picture at some point. No, that's a great story. I'm glad she was able to get the treatment she needed and the funds were raised using social media. So now I'm going to call back up Osama to close out our session. And thank you so much to all of our presenters. I think let's all give them a big round of applause.
Yeah, this is so impressive, thoroughly impressive, very, very energetic. In fact, earlier I was feeling that, it's not good to have not so many people. Now I'm feeling bad for them that they missed such a, great session. I think this session itself is a wrap-up session in the sense that now we know exactly what is happening in all these countries. And in just 35 minutes, we know exactly what is happening. This is a great case study. I think we would be very happy to publish a, case study book of all these small cases from each country. If you, Ashu, maybe we can take it forward and, we take responsibility to print it and publish it. If you contribute about 1,000 words on each of the country, or maybe 2,000 words with small 200 words for each one of them, let's do it. But great show. Thank you very much for doing this in 5 minutes. Everybody did in 5 minutes only. Nobody crossed the limit, which was great. It was absolutely non-South Asian. We were punctual, we were, energetic, we were, aggressive, and we were panting, some of them. So is there anything else that we need to talk at this moment of time? I think before we go out of this room, let's one by one give our country guest a great applause to all of them for their presence. I'll call the name from Bangladesh. Who is from Bangladesh? Can you please get up and give them an applause? From Pakistan, from Maldives, from Sri Lanka, from Nepal, from Bhutan, and our smallest part, India. And somebody was from Tibet on their own, I guess, but anyway, so thank you very much. It was great having you for 2 days. I think it was great energy. Thank you very much for all of you. And I would, on behalf of DEF and on behalf of American Center, would like to, say sorry if there was any, shortcomings, and if there was any mistake, if there was any, shortcomings in hospitality or any traveling around or anything. But you still have a couple of days for many people I know who are going to be around. Have fun. Look at the Great Delhi. It's a great weather, unlike usually, in this month. Look around. Let us know if we can be of any help. Thank you very much. Let's have a cup of tea together. meet her here to take their packets. I'm sorry.